The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you with the FlightBridgeED Podcast. Today we're going to have a very, very cool podcast. I've got a special guest, Dr. Zaffer Qasim. Welcome.
Great. Thanks for having me, Eric. I really appreciate it.
Well, we really, really appreciate you coming on and discussing such a cool topic. You know, obviously there's been podcasts put out specifically by MCRIT, Scott Weingard, beginning of, I would say, last year. And I've kind of waited to put anything out and just kind of to see what is happening in the field of REBOA. And so we were introduced by a colleague that listens to the FlightBridgeED Podcast. So I really appreciate him bringing you to the FlightBridgeED listeners and that we can have an expert in the field discuss such a cool new treatment. So if you wouldn't mind, just really quickly go through your training, your background, and your clinical discipline.
Yeah, of course. Yeah. So I trained as an emergency physician and I practiced a while in England before moving to the U.S. a few years ago, mainly to complete a trauma and critical care fellowship at the University of Maryland's Shock Trauma Center in Baltimore. And decided to stay on in the country, and I currently work at the emergency department of Christiana Hospital, which is in Delaware. In fact, it's the only level 1 trauma center for the state. And while I was there at Maryland, I was extensively involved with REBOA. I teach on a course there, and I brought that knowledge up to Christiana to set up the REBOA program here.
If you wouldn't care, kind of explain what REBOA stands for and the history of REBOA.
Yeah, sure. So REBOA stands for Resuscitative Endovascular Balloon Occlusion of the Aorta. And what that means is you're passing a catheter through the femoral artery up into the aorta and inflating a balloon above the level of bleeding that you suspect is happening in these patients. And essentially what you're doing is then internally cross-clamping the aorta. So as with many things in medicine, the idea of balloon occlusion isn't something that's completely new. In fact, you can trace back REBOA back to probably the Korean War, where there was a fairly innovative vascular surgeon called Lieutenant Colonel Hughes who used a type of balloon occlusion device to try and save 3 critically injured soldiers. But it never really got traction until about the turn of the century when the vascular surgeons started exploring and developing and proving that minimally invasive endovascular techniques were working in managing AAA patients, so people with ruptured AAAs. And what was important to learn from their work was that these patients were able to tolerate these minimally invasive procedures and techniques a lot better than the laparotomies that they were getting before then. And so certainly that contributed to the improved outcomes that the vascular community was seeing. And so the military certainly was very interested in exploring ways of improving mainly combat casualty care. Remember, this was a time when there were wars being fought on several fronts. And so a lot of emphasis and research got put into looking at animal studies that might support the use of REBOA for hemorrhagic shock. And the animal studies were very promising. They showed certainly improved cardiocerebral perfusion. They showed in some models that there was improved mortality. And similar to what the vascular surgeons were seeing, they showed that when compared to a procedure like thoracotomy, the use of REBOA was actually better tolerated by the animals that were getting it. But of course, we wanted to see what it would be like in humans. And so several case series had come out looking at its use in the U.S. as well as abroad, and showed that in the cases that it was successfully used in, those patients were not dying from hemorrhage. But those were only case series, and so certainly the trauma community was really interested in looking at whether this was of broader use or benefit. And so currently there is still a need for ongoing study, and there is one such study in the United States called the Aorta trial, which is going to run for a little while longer, which is comparing the outcomes from REBOA versus thoracotomy to truly see the benefit of one over the other in terms of survival. And they actually published some of their data from their interim analysis in the past month. And really, that's where it's come from and how it's developed here in the United States.
Is there a time difference when you consider thoracotomy to placement of the balloon, either in the different zones? Is there a time difference? Is that something to consider, or is it pretty much the same?
Yeah, so I think the real rate-limiting step in performing REBOA is getting into the artery. And you can imagine if someone's really, really shocked, that artery is going to get smaller and smaller and a much harder target. So that's the real kind of rate-limiting step. But having said that, the Aorta study actually looked at the timing of doing REBOA and placing a cross clamp versus, thoracotomy and placing a cross clamp and doing REBOA, and found that, interestingly, the times to do both procedures were pretty much the same. So in appropriately trained hands, you can achieve that aortic occlusion in fairly similar times. You do place it in the common femoral artery, and I certainly advise trying to get that line early if you suspect that there's a critically injured patient who might benefit from REBOA. Get that line early so that that's in place, and you've taken care of that rate-limiting step whilst they still have a reasonable caliber vessel to access. And it's important to access the common femoral artery because some of the equipment that you'll utilize can have the potential to cause pretty significant arterial injury. And so if you put it in one of the smaller branch vessels as the femoral artery bifurcates into the superficial femoral and the profunda femoris, you risk kind of even potentially shearing off that branch vessel and causing kind of devastating injuries in the groin, which are kind of iatrogenic then.
Is there a specific landmark procedure that kind of allows you more success in placing it in the correct place?
Yeah, so it's interesting. So people think about using palpation technique, and people may put arterial lines by palpation, and invariably they end up going a lot lower than they should. So the landmarks to really know are where the inguinal ligament is, and that's between the anterior superior iliac spine and the pubic tubercle. And you find the midpoint of that ligament, and it's about a centimeter or two is a reliable area where you can access the common femoral artery. Having said that, it's just as well to use ultrasound. If you're adept at using ultrasound, certainly I would advise utilizing that, because then you can visualize clearly where the bifurcation will happen, where the largest caliber vessel is, and potentially, from person to person, there might be some anatomical variation, so you can get on top of that too.
Can you just talk about the assessment criteria? You have a patient come in, multi-systems trauma patient. Kind of what types of injuries are you looking for? Is there specific injuries that this is utilized for over others? And kind of talk about your decision-making when it comes to that.
Yeah, sure. So the people who are going to benefit from REBOA are those with devastating torso hemorrhage. So that's bleeding areas that you don't or are not able to apply direct pressure to, like the abdomen or the pelvis or the retroperitoneum. And additionally, those people who are refractory to your standard damage control resuscitation techniques. So, in fact, those people who are highly likely to code in front of you. And so REBOA potentially buys these folks some time to get them to definitive care. So certainly high-grade pelvic fractures, as well as severe intra-abdominal hemorrhage from, say, solid organ injuries, are all potentially amenable to REBOA. And likely in systems that are seeing a lot of blunt trauma, the pelvic fracture with massive arterial disruption is going to be relatively more common type of patient that might benefit from it. These are patients who look reasonably well until they suddenly don't, and they carry a high mortality, so they have the potential to benefit from utilization of REBOA. So in my mind, you have to fulfill those two criteria, that they have devastating torso hemorrhage as well as they're refractory to hemorrhagic shock for them to qualify for REBOA. And additionally, and some people advocate, and I'm one of them too, that it can be used in traumatic cardiac arrest, but with great care. The key issue, I think, is you have to witness the cardiac arrest. So not someone who's like died in the field and you're not quite sure how long they're actually down for. But if they come into your environment and they die in front of you, they could potentially benefit also. The other thing to be aware of is who's not going to get it. So you certainly don't want to use it in anybody who has a bad chest injury, like a tamponade, for example. So that's likely to only get worse if you put a balloon up in the aorta. And so you have to have some sort of mechanism to be able to try and identify these, either by understanding injury patterns or using X-ray or ultrasound if you have that available to you. And I think one other thing that should be a contraindication, and I'll talk about this a little bit more, is perhaps looking at your logistics. So if you don't have a means of getting these people to definitive care fairly rapidly after you put in REBOA, then maybe you should think twice about putting REBOA in these people too.
Okay, so as far as the pelvic injuries go, and then I'll elaborate on what you just said, are we talking about specifically just a simple open book pelvic fracture, or are we talking about catastrophic vertical shear type of a pelvic fracture that is probably most common in causing exsanguination?
Yeah, so I think much more commonly the vertical shear type of injury, only because the risk of associated arterial injury is fairly high with those. Having said that, it's sometimes, unless you kind of truly understand the injury mechanics, it's sometimes difficult to differentiate, and sometimes you'll just have one person who you're not quite sure what their injury pattern might be, but you suspect they have a bad pelvis, and they're trying to die in front of you. So certainly important to keep in mind the injury mechanics, and those are likely to benefit most. But at the same time, if you're faced with someone with catastrophic vitals, they're about to die, then you could just go ahead based on the limited information you have.
When you look at, I think you talked about cardiac arrest and the application, and that was a question that I had as far as, you said earlier, if these people are in profound shock, these patients are in profound shock, cannulating that femoral artery is going to be difficult. And so, what are the kind of the parameters of, are you going to place REBOA in a traumatic cardiac arrest, and how much more difficult is it to cannulate that? And do you have to use ultrasound? I mean, is that kind of a must in that situation?
Yeah, so I think that brings up a couple of things, because these people will be extremely difficult to cannulate because they have no output, and you certainly can't use any kind of guidance with regards to pulsation or anything to guide you. Anatomical landmarks may help, but oftentimes in these cases, people will end up doing a cut down onto the groin. And onto the artery in order to access it. And that's kind of looking at some of the limitations of who can deliver REBOA, because that's a skill set that not everybody has. Ultrasound, if you're very good at it, can be utilized. But again, remember, these guys might have an extremely tiny vessel now that you can't really see very well. Plus, there might be compressions going on and things like that. So trying to access the artery in that instance, while it's not impossible, is much more difficult. But so I would say, go and fall into the skills that you're, that you do well. So if you know how to do cut down, then that should be your default. If you're very good at doing ultrasound, then stick with that.
Is there any data or you have any specific cases where you have seen REBOA placed in a traumatic cardiac arrest patient and you've had survivability from that, or return of spontaneous circulation?
Yeah, so there have certainly been, and I would say I won't go into any of the key patient details, but so personally, one case that I had that had return of circulation and actually had a pretty good outcome after a witnessed traumatic arrest. Again, we did a zone 1 balloon for multiple injuries to the abdomen, and that had a good outcome. And certainly my colleagues at Shock Trauma have had some really great saves with, again, witnessed traumatic cardiac arrest that have gone on to have, pretty good neurologic outcomes.
You just talked about some terminology that I wanted to ask you about, and that's the different zones. For you listeners out there, we're going to place these things in the show notes, so you'll have to actually go to the FlightBridgeED website, look underneath the podcast, and you'll see these in PDF form. But there's different zones. We have Zone 1 and specifically Zone 3. So can you talk about those different zones and injury patterns in conjunction of why you would use one zone over the other?
Yeah, sure. So certainly for the purposes of balloon inflation, we'll divide the descending aorta into 3 zones. So Zone 1 is from the left subclavian artery down to the celiac trunk, and that's an area that you want to place the balloon if you're suspecting either subdiaphragmatic bleeding or if you're not 100% sure where in the torso the bleeding is coming from. Zone 3 is from the lowest renal artery down to the aortic bifurcation, and that's primarily where you'll place the balloon if you suspect pelvic bleeding. And then the zone in between is Zone 2, but that area has a lot of different branch vessels coming out of it. So there is a potential that if you put the balloon up there, you might not actually occlude the vessel that's responsible for the bleeding. And so you want to try and avoid that. So Zone 1 and Zone 3 are your primary areas that you're going to target.
So just kind of thinking about this, and I know this has been used in vascular surgery, in AAA repair, in the OR for quite a long time. Let's say it placed the balloon in Zone 1. Is there a specific way that you identify the correct location? Is there a measurement that you use? Do you use ultrasound? What do you do?
Yeah, so as opposed to what the vascular surgeons are doing, REBOA in the purposes of trauma is mainly done without the benefit of having fluoroscopy. So you're really measuring whichever device you choose to use against external landmarks. So for Zone 1, the typical landmark has been the distance from the xiphisternum down to the area that you're accessing the artery. And you'll measure that distance and mark it and go ahead and place the catheter up to that point.
And as far as time goes, you're occluding off. Is there any collateral circulation getting around that balloon inflation, or from where that balloon is inflated all the way down, is there any circulation at all?
Yeah, so it's, and that's kind of one of the key things with what we know about REBOA and the way it's utilized right now, that pretty much all the circulation is cut off. There might be a little bit of trickling from around the sides of the balloon, but essentially you're cutting off the circulation completely below that. And certainly that has implications, especially if you're putting the balloon up in Zone 1. So essentially once the balloon is up, your biggest enemy is time. And we still don't have a clear answer about how long people will truly tolerate a balloon, and it varies from zone to zone. Zone 3 is probably going to tolerate the balloon longer than Zone 1. And so far what we know from the animal literature is that Zone 1 placements seem to support balloon times of 40 to 60 minutes before you develop irreversible end organ injury.
Is there ever any adverse effects after, if it is a positive outcome?
Yeah, so I think you have to keep in mind, especially in Zone 1, that you're taking out the circulation, especially to the kidneys and also potentially to parts of the spinal cord. So there's always the risk of developing renal failure afterwards. There's always the risk of developing gut ischemia and, worryingly, potentially even spinal cord ischemia, which might lead to paralysis of your lower extremities. So that's from the balloon being up, and then you also have to factor in the potential for arterial injury and limb ischemia from the device itself. So you're placing a fairly large sheath to pass the balloon through, and that has the potential to either damage the arteries it's going in, and even kind of occlude flow to the limb, or even set up a thromboembolic phenomenon that might affect the circulation of the lower extremity. So limb ischemia is one of the other potential complications that you need to be wary about.
Let's kind of jump into where you see this applied in the pre-hospital setting. Where you see it applied, I know London HIMSS, they currently do it. I know a physician from that service obviously was the first physician to do it in the field. Mm-hmm. But can you talk about if you see this becoming something that is going to be done in the pre-hospital environment Is it something you see as beneficial, or do you think that the risks outweigh the actual procedure? The UK and Australia and a lot of parts of Europe, there's physicians on the helicopters, and there's very few services in the United States that hold that model. Most of them are RN, paramedic driven. So elaborate on where you see this and who you see doing this.
Yeah, so that's a great question. I think there certainly is a role for REBOA in the pre-hospital environment. As you say, the London HEMS model approved this, but it's a lot of what we know is based on their great work. And I think if you want to kind of translate that into, say, an environment like here in the United States, then you have to answer or look at a few different things. First of all, first you have to see if there's really a need within your system for it. So, and I think that's important. You need to take a long and hard look through your case mix and see if it's actually something that's going to benefit the patients that you serve. And after that, I think you have to look at whether your own system, and so that's pre-hospital coupled with the hospital that it's linked to, will kind of support the use of REBOA. So imagine you go out and put REBOA in the field, where's that patient going to go? And which facility will take them, and are they geared up to manage that sick patient, along with having the expertise of understanding the physiology surrounding REBOA placement. And if the answer to those questions is yes, it's feasible, then can you get them there in a timely fashion? So the transport times, for example, in London are really, really short. But if you look at a lot of areas around the United States, that's a different playing field. Some of the transport times can be extremely long. And so remember, once the balloon is up, the clock's ticking. And so you have to factor not only the transport time, but kind of the intangibles of your transport time, like, the loading, the offloading, the packaging of the patient, all those kind of things, which add extra minutes to your transport. And so if you still think it's feasible, maybe you have to look at how you deliver these patients. Maybe they bypass the emergency department and go straight to the operating room, and that can save a few minutes. So you can kind of look at solutions that way. So I think, and this is what the London HEMS model did, is I think you have to work out these kinks first within the hospital that you serve, say whatever the level 1 is in your system, and make sure that it works there, so that if you decide to move on to a pre-hospital environment where you're delivering this, then the steps to get them to definitive care are pretty seamless and have already been worked out. I think the other thing you have to also address is that, or is your system doing everything else really well? So remember, REBOA is just a tool in the box. So if your system's not geared up to deliver trauma care or basic patient care very well, then and this is the same for in-hospital teams, then it doesn't matter if you have REBOA or not. If you're missing out the basics, then they're not going to benefit. So when you look to who's actually going to do the procedure, I think the answer to that is also within your own system. So if you look at pre-hospital systems around the world, for example, if you look at RSIs in the UK, for example, or in some parts of Europe, it's always the physician who is delivering RSI in the field, as opposed to here in the United States, where it's oftentimes paramedics and critical care paramedics are trained to do it, and they do it well. As far as who's doing it, kind of becomes a mix of the culture, the training and skills, and also what the oversight is. And just like anything like RSI, for example, you have to maintain those skills. And that's where kind of the trend moves towards physician delivery of REBOA, because the skills being utilized for REBOA, like ultrasound or Seldinger technique, are skills they also utilize in the hospital for, central access and things. So they're kind of maintain that muscle memory. And if you kind of add, in the pre-hospital environment, it's an austere environment, and they have a sick patient, they're not familiar. So it really comes down to your muscle memory to be able to do the procedure. So if in your system that's the physician who's best able to do that, then it should be the physician. That doesn't mean that paramedics or PAs or flight nurses can't learn to do the procedure, because a lot of them do, and certainly the technical skills behind it can be taught. But you have to have a kind of a robust environment where they're continually maintaining that training, able to keep practicing it, have a robust kind of quality assurance program to make sure that if you do decide to go forward with it, then there's adequate support to be able to deliver it, rather than just kind of running into it. But another way to kind of look at it is to have a team approach. So if you do have any kind of model where whoever's the operator, physician or paramedic or whoever does the procedure, you should have kind of a buddy system where task the proceduralist to do the procedure, but then the other person in that team, be that the paramedic, nurse, or doc, or whoever, is running the code or running the resuscitation and maintaining situational awareness. Because remember, it's not all about the procedure, it's also making sure that there is excellent care and those elements that are there to kind of support the delivery of REBOA. So yeah, I think that's my take on it. And I think even if you're not working with a system where you're providing primary response to, say, a field trauma, you might well be put as part of your transport team in a role where you're transporting people who have had REBOA at an outside hospital. So it behooves you to kind of understand what REBOA is about and the implications of having that in place whilst you're transporting. So certainly that's another aspect of the way critical care transport in the United States is shaped to deliver care. That's one aspect that should be looked at too.
Well, yeah, those are a lot of pieces to the puzzle. I mean, I completely understand. You can be placing this in the field, but obviously the hospital, these level 1 trauma centers that you're taking them to, they have to be able to manage these patients. So,
right.
Yeah, logistically, I think this is years away. I could really see this being applied in very specific hospital-based programs with 1 or 2 aircraft, a staff that is working alongside trauma docs like yourself in the ED and honing those skills and then applying those and bringing them back to that hospital. I could easily see it applied probably now in that situation. But right. As far as a systemic application, man, I think, you bring up a lot of excellent points, and there's a lot of logistics there that man, and then you think about the cost in training and
right.
continuous training, and what do you think about we talk about this a lot, prophylactically placing pelvic binders on every single multi-systems trauma patient. I mean, whether you get a pain response from a pelvic palpation or not, you put a pelvic binder on and then allow the trauma center to remove that. Is that something you see as beneficial?
Yeah, so I think it's great if you're right, and if you don't do it and you're wrong, then you could land in a world of hurt. So as long as you kind of know and understand what you're doing in the setting of multi-system trauma, and a person who's unconscious, putting that binder on as the first step, it could be part of your comprehensive trauma care. So certainly, I think systems that are doing that, they have. I think it's beneficial. I
mean, yeah, you never know. So, we really try to push that and make sure that, if in doubt, always place it in with our transport times. I mean, most aircraft that I'm familiar with in our area, and transport times are no greater rotor-wise than an hour. I mean, there may be those few circumstances, but I think probably average between 20 and 30 minutes. Has there been a definite reduction in mortality? And I know they measure this usually at 28 days, 30 days. I mean, when you look at that from that perspective, I mean, there's so many other things that play into that, obviously,
Yeah.
I mean, so many things. But, I mean, do you think it's making a difference?
So, as far as kind of the data surrounding that, I think one of the big problems has been that the papers that have come out have primarily been case series. And so it's difficult to kind of get true mortality figures from that. And the one kind of trial, the Aorta trial that published their interim analysis results, seemed to show no difference in mortality as far as comparing it to something like thoracotomy. And kind of the flip side of looking at that is saying that it's no worse than doing a thoracotomy. But I think, one of or a couple of things to look at is, one, these people are extremely sick anyway who are going to get this. And so inevitably, probably the majority of people are going to die just from the severity of their injuries. But what's happening to the people who do survive? Are they surviving with an intact brain or not? And I think that's where kind of REBOA may well show its true benefit, because if you're placing this before the patients lost their vital signs, and so they haven't undergone that degree of hypoxic injury to their brain because they've lost their output, then even if the mortality is the same as other techniques to control hemorrhage, as long as you're getting better neurologically intact survival, maybe that's the true benefit, and that's the thing that you should measure with REBOA, because certainly this is something you can do proactively as opposed to the thoracotomy and aortic cross clamp, which you're essentially waiting for the patient to arrest before you're proceeding with that. As we move forward, there is a lot of evidence that's still coming out. It's a pretty exciting topic that people are putting in a lot of work to try and understand and try and get the right nuances about. Even, if you just search today, there were 2 more papers published on PubMed that weren't there a week ago. So the research into this is really moving forward very quickly. And we still have to, I think we have to tighten how we select our patients a little bit better. And I think there are some technologies and techniques that are coming out, like the potential for partial occlusion as opposed to complete occlusion, which might buy people more time and might decrease the risk of end organ injury. That's already showing promise in the animal literature. So I think people need to certainly understand what REBOA is about, because it has the potential to really become a bigger part of overall trauma care over the next few years.
As I said before, we're very, very lucky to have you. I know your time is precious and you're a busy guy, and we really appreciate you coming on and just sharing your experience and all your knowledge, and we really appreciate that.
No, I really enjoyed being part of this. I've listened to some of your podcasts, so and you do a great service to the flight community and the critical care transport community. So thanks for having me.
Well, that's a great honor that you say that. We really just try to put out information so we can kind of share that. I really believe that, we're much smarter collaborating together and learning from each other and our experiences. And if we can make that reach as far as possible, try to make some ground and become better and stronger. So that's kind of the vision of FlightBridgeED, and I appreciate you saying that. On behalf of Dr. Zaffer Qasim, we just want to thank you for joining us. As always, if you have any questions, I will. Is it all right if I put your email in the show notes?
Yeah, sure. No problem.
If anybody has any questions, they can reach out to either of us. Again, I will put the picture that we get a PDF of a protocol of the different zones and things like that in the show notes. And as always, we will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.